All. So from today onwards, we'll start case-based discussion. We'll go through GB syndrome case, so which is very important for all sort of practical exams, whether it is a EDIC Part 2 or DM, DRNB, IDCCM, IFCCM. So all sort of critical care practical exit exam. This case is very important. So I just want to make a point. So whenever you are preparing for a case, some aspects are general, some aspects are specific to that case. So general means in any of the case, your plan for nutrition, difficulty in weaning, infection control policies, how you are going to intubate, okay. So fluid therapy, hemodynamic monitoring, all these things are going to be general for any sort of the case that you should have in your mind, okay, when you are presenting a case or when your case based discussion is going to start. And you should have thorough knowledge on a specific therapy particular to that like disease or the syndrome kind of this one, okay. So are particular to that case. So this is the two way in a broad way how you can get an idea. So what you need to have some sort of preoccupied things when you are going to start with your case discussion and all. So we'll try to go through the GB syndrome patient. So here I am going to take the question answer from my side only. So we'll go through a hypothetical case. So initial presentation. So 38-year-old male present to emergency department with difficulty in walking and weakness in both legs that started 2 days ago and has progressively worsened. So he report that he was completely healthy until a week ago when he had an episode of watery diarrhea, so which resolved on its own. So on clinical examination, his temperature is 36.8 degree Celsius, heart rate is 108. So blood pressure 118 by 64, respiratory rate 24 per minute, saturating 94% on room air. So his GCS is full 15 by 15. So his pupils bilaterally equal and reactive 3 millimeter. So quietly young patient, okay, so who had some history of difficulty in walking and weakness in both the legs. So 2 days history, so some sort of history of the watery diarrhea. So how you are going to approach to this patient? So what is your initial evaluation and investigation? So this is how your case is going to start. So what way you are going to approach to these kind of patients? Okay, you know that. So there is a concern in and around like neuromuscular system, so neurological system. So what is your general approach when you receive a patient like this with some sort of clinical examination here? Okay. So remember, so when an examiner asks your approach again, so airway, breathing, circulation, all these things you are going to consider with a backup of some sort of, okay, what is need to be done for that particular patient. So in this patient, there is some sort of weakness of the lower limb. So we are going to assess the airway in terms of assessing the quality of the voice. So swallowing, whether he is able to swallow adequately or not. So look for the signs of respiratory distress in terms of breathing, whether he need acute support. So shallow breathing is there, use of axillary muscle is there. So circulation, so anyhow we got blood pressure of around 120. So heart rate, whether tachycardia is there. So mean arterial pressure is adequate to maintain the perfusion. So with the background of some sort of, okay, is there any variation in terms of heart rate, high, low, BP, high, low, which explains some sort of dysautonomia. So disability, again, we get an idea by GCS pupil, any focal neurological deficit other than this weakness. So we'll examine for any sort of infectious source because he had some sort of diarrhea history. So like rash, any trauma evidence of recent surgery or injection. Okay. So this is some sort of initial examination. But so when you are examining as a receiving end, you need to have some sort of additional focused history taking, particularly these kind of patient. So symptom onset and progression. When did the weakness start? How has it progressed since then? So symmetry and distribution. Did both legs weaken at the same time? Are arms also involved now? Sensory symptoms, any tingling, numbness or pain in the limbs is there. So cranial nerve involvement and history wise, okay. So any difficulty in swallowing, speaking, double vision. So autonomic symptoms like any palpitation, dizziness, on standing. What about is bladder and bowel involvement? So recent infection, have you had fever, cough, sore throat? So diarrhea recently, as he already told, like 2 days back, he had episode of diarrhea. So vaccination, travel history, very, very important. Have you received any recent vaccination, travel to any sort of endemic area? So family or autoimmune history. So any family history of similar illness, autoimmune condition in the family. So drug or toxin exposure. So any recent use of antibiotic, insecticides or illicit drugs. So basically examiner at least expect 3 to 5 in terms of focused history taking from your side. You should remember these subheadings. Okay. So when it comes to focused neurological examination, so you have received the patient and you assess the airway, breathing, circulation and all. So quickly you need to do some neurological examination also. Remember, say certain examiner, when it is going to be a bedside, so they might be interested in you to tell some sort of the subheadings of neurological examination. They might ask you to demonstrate also. So particularly in this case, motor system, check for the tone. So is there any flaccidity is there with the decrease in tone? So power, what is the difference between power in the distal or proximal weakness? So starting with the legs that you need to check. Reflexes, whether abolished deep tendon reflex or it is intact. So muscle bulk, okay. So any fasciculation is there. So all those things you need to examine here. None of the fasciculation are there. Sensory system, generally it's going to be intact in this particular patient. So minimal distal paresthesia is there, no definitive sensory level. So cranial nerve examination, so facial weakness, ptosis, ophthalmoplegia, bulbar weakness with the involvement of the cranial nerve 9 and 10. So you need to keep that in mind. So watch for facial, so diplegia, so common in GV syndrome, cerebellar like our coordination, usually cerebellar involvement will not be there in GB syndrome. So respiratory muscle function, so is he able to count a single breath, auxiliary usage of the muscle. So next, objectively, negative inferior force and that of the forced vital capacity. So again here, so at the beginning only, none of the examiner is going to expect all these things, but at least you should know. So when you have some preoccupied thing, so this is the diagnosis, you should know what you are going to do in terms of the focused neurological examination. Very, very important. Okay. Some are very much interested, some might like interested to get to know some sort of the positive signs, but you should prepare thoroughly. So next question. So what blood investigation will you order in this patient and what is the rationality for those investigation? Okay. So you received the patient, you done a initial history and that of the targeted neurological examination. So then you need to work up further. So what are the blood investigation you wish to send and why? What is the rationality? So again, so remember, so this is the battery of investigation, but whatever you tell, you should have a rationality for that. So essential blood investigation and the rationality. CBC, want to rule out any infection. So whether any leukocytosis, anemia, so cytopenia, particularly if patient is immunocompromised like HIV or like connective tissue disorder like SLE. So renal function test, urea creatinine to get an idea about the baseline renal function before if you further plan for IVIG plasmapheresis. So we should have an idea about it. So liver function test, screen for liver injury, hepatitis. Okay. So to assess albumin before giving the IVIG and all. So electrolytes, again, sodium, potassium, magnesium, phosphorus. So hypokalemia, hypophosphatemia, hypomagnesemia, all can cause some sort of the muscle weakness. So you need to have a exclusion of these differential diagnosis. So blood glucose, HbA1c, rule out is there any diabetic neuropathy, diabetic ketoacidosis. So calcium, both total and that of the ionized calcium. So hypocalcemia can mimic neuromuscular weakness. So CRP, ESR, which support an ongoing inflammatory process or infective etiology. So that is autoimmune versus that of the infectious cause, we can get an idea. So ABG, definitely it tells about, so is there any respiratory acidosis with a CO2 retention? Is there any hypoxia or metabolic abnormalities? So creatinine kinase elevated in myopathies or rhabdomyolysis. These are some of the differential diagnosis. So TSH, free T4 to rule out hypothyroid related myopathy, B12, folate. So again, its deficiency may present in any kind of neuropathy. So lactate. So again, rarely if patient is having some sort of mitochondrial or metabolic encephalopathies. Okay, neuropathies or hypoxic cause for the weakness. You can get an idea. So HIV, hepatitis B and C serology. So infection associated with neuropathy, particularly HIV can itself have a HIV associated GB syndrome. So ANA profile, anti double stranded DNA, ENA profile. Okay. So to assess autoimmune etiology, particularly SLE and Sjogren's syndrome. So next comes specifically, okay, remember, so need not to tell at this level. So that is ganglioside antibodies, the anti-GM1, if available, may support the subtype of the GB syndrome, whether it is an MN, okay, Miller-Fisher variant that we can get by so ganglioside antibodies. Again, I am telling, so examiner might not expect in the initial like your evaluation only, but you should remember. So this is the battery of the test. So blood culture, if patient had a fever history, so then we can get an idea about the sepsis related some neuropathy or myopathy kind of this one. Okay. So again, so at least major investigation you should be able to tell with the rationality. Very, very important. So next we got a ABG of our patient and couple of biochemistry. So pH 7.36, PCO2 41, PO2 is 85, and room air bicarb 23, lactate normal 1.5, so saturating around 95%. Okay, so we got the value of sodium 138. So potassium is borderline 3.1, creatinine normal, magnesium again borderline 1.6, so calcium 8.3 total. So phosphate it is okay, so like upper normal limit. So CPK, LFT all were normal. Okay, so this is a young patient who had a history of weakness, bilateral lower limb with one episode of watery diarrhea. So this is the biochemistry under of the ABG. So will you require any other investigation at initial evaluation? Means like you need some more data on this patient or you are able to narrow down the investigation. So that is the next question. Okay. So what about neuroimaging? Will you consider so any sort of neuroimaging like MRI, CT in this particular patient? Okay, how urgently you need to do, because typically is having a lower limb weakness. Okay, so remember when you have some sort of this acute or subacute onset of the weakness, so urgent imaging is definitely needed. Okay, rapidly progressive weakness is there, sensory level involvement, bladder bowel involvement is there, so hyperreflexia, UMN upper motor neuron lesion like Babinski sign, suspected spinal cord compression, asymmetrical or non-length dependent weakness. So fever plus back pain. So is if you are excluding some sort of epidural abscess. So if you are suspecting that, so then urgent imaging is needed. So if it is a clear cut only lower limb involvement, so no need to jump on getting an image. Okay. So, but so if patient is having a focal neurological deficit, if our differential diagnosis is towards an ischemic or an hemorrhagic infarct with a facial deviation, slurred speech and all, so definitely you need to get a imaging, that is a plain CT, so as early as much possible, so according to your NINDS timeline of the stroke. So that is a stroke protocol. Okay, so in suspected GB syndrome, MRI spine may show gadolinium enhancement of ventral nerve roots, so but not always necessary unless atypical presentation or diagnosis is uncertain. So it is not mandatory to get an MRI when you have a so clinical picture which is fitting into some sort of GB syndrome. Okay, so if you see importance of neuroimaging in acute weakness in general, you need to understand. So to rule out central causes, particularly to differentiate between UMN or LMN lesion like spinal cord infarct, demyelination syndrome or compression. So to detect compressive lesion, particularly spinal cord compression with epidural abscess, tumor, hematoma. So, or if there is any emergency indication for surgery, assess for transverse myelitis. Okay, MRI spine with contrast can detect so inflammation or demyelination of the cord. So, in post-viral syndrome, autoimmune disease, multiple sclerosis. Okay, so all these things you need to take a call on doing a MRI spine. So, exclude structural brain lesions in altered mental status, seizure or cranial nerve involvement. So MRI brain rules out the infarct, encephalitis or demyelinating disease. So support the GB syndrome on MRI as I already told. So GB syndrome is clinical plus electrophysiological diagnosis. So MRI spine may show narrow root enhancement in cauda equina or lumbosacral plexus, especially in children. So which if they are having a variant type like a so chronic inflammatory, so like polyneuropathy kind of this one. Okay, so demyelinating pulse, that is CIDP. So which also guides the lumbar puncture if uh, it is safe to do CSF or not, so that if you have a brain imaging, so it helps in ruling out any sort of rise in intracranial pressure, so that we can safely proceed with the lumbar puncture. So these are some of the rationality if at all you want to commit, okay, you want some sort of neuroimaging. So again, preferred imaging modalities in any patient with this clinical background. So MRI spine with contrast. So first line if spinal cord pathology is suspected, as I already told. So MRI brain with contrast if cranial nerve involved, so altered consciousness is there, suspicion of CNS demyelination or encephalitis is there. So CT spine if MRI is unavailable. So CT brain used as an initial screen if patient is having altered sensorium, seizure, or contraindication for MRI is there. So this is an overview on your comment on the need of neuroimaging in this particular patient. Very, very important. Okay. So move on to next question. What are your differential diagnosis? So for a subacute onset of the lower limb weakness in this particular patient. So young male, so who is having a subacute lower limb weakness. So how you are going to have a differential diagnosis at this level. Okay. So if you see like GB syndrome is going to have a ascending symmetrical weakness and areflexia, so which is going to have some sort of recent infection background. So transverse myelitis often asymmetrical, sensory level will be there, bladder involvement will be there. So cardiac venous syndrome, saddle anesthesia, bladder bowel symptoms are there. So myasthenia gravis, atypical myasthenia. So typically, which is going to affect the cranial muscles as the first involvement. So hypokalemic periodic paralysis, usually it's going to be episodic, no sensory involvement. So and it is going to very well respond to the potassium therapy. So these are some of the differential diagnosis. You can tell 1, 2, 3 to your examiner. So this is the table, so which clearly suggests in details about like the differential diagnosis of acute flaccid paralysis. Okay, so neuropathy, that is peripheral neuropathy, include GB syndrome. So acute motor axonal neuropathy, acute inflammatory demyelinating polyradiculoneuropathy, vasculitic neuropathy. Vasculitis is very important. So neuromuscular junction, that is myasthenia gravis, botulinism, so Lambert-Eaton myasthenic syndrome. So myopathy, that is purely muscle involvement. So hypokalemic periodic paralysis, polymyositis, dermatomyositis. Okay, so spinal cord or anterior horn, anterior root involvement. So that is transverse myelitis, spinal cord compression, tumor abscess, so poliomyelitis, which is rare in today's instance. So next, toxins or metabolic involvement. So OP poisoning, tick paralysis, acute intermittent porphyria. So this is the table. It also tells about the key features of the differential diagnosis of acute flaccid paralysis. Very, very important. Very, very important. So you might get a sensory level will be there, bladder involvement will be there. So cardiac venous syndrome, saddle anesthesia, bladder bowel symptoms are there. So myasthenia gravis, atypical myasthenia. So typically, which is going to affect the cranial muscles as the first involvement. So hypokalemic periodic paralysis, usually it's going to be episodic, no sensory involvement. So and it is going to very well respond to the potassium therapy. So these are some of the differential diagnosis. You can tell 1, 2, 3 to your examiner. So this is the table, so which clearly suggests in details about like the differential diagnosis of acute flaccid paralysis. Okay, so neuropathy, that is peripheral neuropathy, include GB syndrome. So acute motor axonal neuropathy, acute inflammatory demyelinating polyradiculoneuropathy, vasculitic neuropathy. Vasculitis is very important. So neuromuscular junction, that is myasthenia gravis, botulinism, so Lambert-Eaton myasthenic syndrome. So myopathy, that is purely muscle involvement. So hypokalemic periodic paralysis, polymyositis, dermatomyositis, rhabdomyolysis. Okay, so spinal cord or anterior horn, anterior root involvement. So that is transverse myelitis, spinal cord compression, tumor abscess, so poliomyelitis, which is rare in today's instance. So next, toxins are metabolic environment. So OP poisoning, tick paralysis, acute intermittent porphyria. So this is the table. It also tells about the key features of the differential diagnosis of acute flaccid paralysis. Very, very important. Very, very important. So you might get a question, okay, how you are going to differentiate between so GB syndrome and that of the myasthenia gravis. If you see in myasthenia, so it is a fluctuating weakness, ptosis, diplopia, reflexes are going to be preserved. Okay, so you should have that like idea. Botulism, so it is having a descending paralysis, pupillary involvement, so autonomic features are going to be there. So basically, so these are some of the differentiating key features. So you can just go through this table. So in terms of overall differential diagnosis for acute flaccid paralysis. So next, we got some additional history and other clinical findings in our patient. So the patient denies any trauma, back pain or urinary symptom. So we also mention tingling and numbness in the feet. So on examination, so when we received the patient in ICU, we found motor power is 3/5. So in both lower limb, 4/5 in the upper limb. So reflexes absent in all four limbs, areflexia. So sensation, it is intact to pinprick and vibration. So cranial involvement, cranial nerve involvement is not there. So all cranial nerves are intact. So his vitals, heart rate is 90, BP is 130/80, respiratory rate is 20 per minute, is saturating 98% on room air. So we got some more information, okay, with this clinical manifestation. So when we received the patient in intensive care unit. So based on his clinical picture, what is your most likely diagnosis and the key features which are supporting your diagnosis, okay? So here you are trying to narrow down your diagnosis after. So based on the clinical picture, so we are narrowing down our diagnosis to GB syndrome. So most likely it is a AADP subtype. AADP is the clinical subtype. So supporting features, again, you need to support your diagnosis. So there is an acute ascending symmetrical motor weakness is there. So areflexia absent, deep tendon reflexes. So recent diarrheal illness which suggests most likely Campylobacter jejuni is the trigger. So there is no sensory or like cranial nerve or CNS involvement. So all these things, so narrow down your diagnosis towards the AADP variant of the GB syndrome. Okay, you made the diagnosis at this level. So can you comment on pathophysiology and precipitating factor of GBS? That is your next question. So remember, so one hand, so they are asking how you are going to evaluate and manage this patient. On the other hand, so the questions you are going to get is little bit on pathophysiology, etiology, classification and all those things. Okay, so here, so pathophysiology and that of the precipitating factor. So remember, in a simple way, so there are some triggering factors will be there. So usually it is infection like Campylobacter jejuni or CMV, which is going to trigger the immune response. So with that, there is a molecular mimicry. So antibodies against these pathogens are going to cross react with ganglioside on peripheral nerves. So so activated T cells secondary to infection, and the antibodies are going to attack myelin or axon. If it is going to attack the myelin, so then we call it as a AIDP. So if it is going to attack the axon with these T cells and the antibodies, we are going to call it as a MN or that of the AMSN. Okay, so nerve damage, so demyelination or axonal degeneration will be there, which impairs the nerve signal transmission. So that leads to clinical manifestation of weakness, areflexia, sensory loss, so autonomic dysfunction. So in the recovery phase, there is a nerve regeneration and remyelination is going to happen, which takes weeks to months. So this is a simple understanding of molecular mimicry, T cell mediated, antibody mediated attack. So at the myelin tissue or maybe at the axon, so depending upon the subtype. So what are the precipitating factors? So again, so here, so just go through this table. It may be infectious causes like Campylobacter jejuni, CME, EBV, HIV, mycoplasma, so Zika virus, vaccination, particularly influenza, rabies. So nowadays it is very rare and it is controversial. Most commonly influenza vaccine. So post-surgery or trauma. So post-operative state or spinal nerve trauma. So systemic illness like lupus, lymphoma, sarcoidosis can have a GB syndrome. So with paraneoplastic manifestation or immune mediated variant. So pregnancy, postpartum, so immune modulation may predispose to GB syndrome in a rare instance. So COVID-19 again, so increasingly reported in the post-COVID or post-COVID vaccination. So GB syndrome scenarios. Again, remember at least 4 to 5 precipitating factor at this level. So next move on to the question. So how will you classify GB syndrome? So and its associated antibody production. So some are very much interested on knowing the particular antibody type. So how you are going to classify the GB syndrome? So here if you see, like we have, so acute inflammatory demyelinating polyneuropathy, so acute motor axonal neuropathy, acute motor sensory axonal neuropathy, Miller Fisher variant, so PCB, that is pharyngeal cervical brachial variant, so Becker's-Tech brainstem encephalitis. So if you see in AIDP, most common variant in the West, so immune attack on the myelin sheath, so which is going to have ascending weakness, areflexia and sensory symptoms. So associated antibody, so we are not able to identify the consistent any particular type of the antibodies. So if you see acute motor axonal neuropathy, which is pure motor, so axonal degeneration, so it is going to attack the axon here, so without any demyelination. Okay, so rapid motor weakness will be there, no sensory involvement, so they are going to have a associated antibody, that is anti-GM1, so anti-GD1A antibody, very very important. So AMSON, so that is acute motor sensory axonal neuropathy, both severe motor and sensory axonal damage will be there, rapid progression, so severe deficit, so anti-GM1 and anti-GD1B will be the antibody. So Miller-Fisher variant, so there is a cranial nerve involvement will be there with ataxia, ophthalmoplegia and areflexia, which is the triad of Miller-Fisher variant. So there is a preserved muscle strength, so abnormal gait will be there. Okay, so that is ataxia and diplopia will be there. So anti-GQ1B, which is specific for the Miller-Fisher variant. So then pharyngeal cervical brachial, predominant effect is going to be in the bulbar and upper limb muscles. So dysphagia, neck weakness, arm flaccid paralysis will be there. So anti-GT1A, sometimes so anti-GD1A is going to be the problem. So then we have Bickerstaff brainstem encephalitis. It is going to have a encephalopathy with ophthalmoplegia, so which is going to overlap with the like Miller-Fisher variant. Okay, so like patient is going to have altered sensorium, brainstem signs are going to be there. So again, anti-GQ1B, sometimes anti-GT1A can be the antibody which we are going to detect in Bickerstaff's brainstem encephalitis. So this is the like classification. At least you should know the major differences and the major classification. So note on this, anti-GM1 antibodies are also associated with axonal forms of GBS and may predict poor recovery. So anti-GQ1B is highly specific for Miller-Fisher variant and related variant like Bickerstaff variant encephalitis. Okay, so not all patients test positive for antibody. So absence of antibody does not exclude any diagnosis. So your diagnosis is going to be clinical. Next is the so neurophysiological nerve conduction test study and all, very very important. Okay, so next move on to the question. Next question, what is the importance of lumbar puncture in GB syndrome? So in terms of the timeline, so when you are planning to do, how to interpret, so very important question. So lumbar puncture, if you see the timeline, so early phase, diagnostic window, late phase, we can classify. So within 3 to 4 days, if you done a LP, CSF may be normal, especially protein is going to be normal. Hence, normal early CSF does not exclude GB syndrome. So after 7 days of symptom onset, that is the diagnostic window, so typical findings are most likely to be seen in and around after 7 days. So best time for diagnostic yield. So more than 2 weeks, that is the late phase. So CSF abnormalities usually persist, so which helps in unclear cases are ruling out other differentials. Okay, so if you see the total interpretation of CSF in GB syndrome, so protein is going to be elevated more than 45 milligram per deciliter, often up to more than 100 milligram per DL. So due to demyelination and breakdown of the so blood nerve barrier. So WBC count usually in the CSF normal or it is very low, less than 10 cells per microliter. So absence of pleocytosis which support the GBS. If more than 50 WBC, consider an infectious or inflammatory neuropathy. It is not GB syndrome. So glucose fairly normal. That again exclude the infective etiology. It helps in differentiating from infectious meningitis, where glucose in bacterial meningitis is going to be significantly low. Okay. So this is the interpretation of your CSF in GB syndrome. So again, so we got a CSF report in our gentleman. So protein is 122, so which is elevated due to nerve root demyelination. So counts are very low, no pleocytosis, it is normal, glucose normal. Okay, so gram stain culture of the CSF is going to be normal, which fairly rules out CNS infection. So this typical like appearance of the CSF, we call it as a albuminocytological dissociation. So remember, so do not rely on lumbar puncture alone in the early phase, which is less than 7 days. CSF may be normal. So best diagnostic yield is after 1 week from the onset. So CSF shows albuminocytological dissociation, which is supportive but not specific again. So if cell count is very high, more than 50 per microliter, so reconsider the diagnosis. It may be CIDP, chronic inflammatory demyelinating polyneuropathy, or it may be secondary to some other infective etiology. That's about the lumbar puncture, its timeline and its interpretation in GB syndrome patient. So next question. So what is the importance of nerve conduction study? So in GB syndrome, so what are the different manifestation? Okay. So like again, so is it going to add to the diagnosis? So definitely yes. If you see like nerve conduction study, diagnostic confirmation, it helps in confirming GBS in uncertain cases by demonstrating so demyelination or axonal injury. So it also gives an idea about the subtype, whether it is AIDP, Amen, Amson or Miller Fisher variant. So prognostication we can do with the monitoring the progression of the disease and research and standardization of the therapy. We can use this nerve conduction study. So when to do nerve conduction study? What is the timeline? So within 7 days early, so maybe normal or show subtle changes useful if strongly suspected and rapidly progressing. So somewhere after 1 to 2 weeks, means in between 1 to 2 weeks, that is the optimal time for nerve conduction study. So best diagnostic yield, so classical features of demyelination or axonal damage we are going to get. So after 3 to 4 weeks helps in monitoring the disease recovery. So it also detect the late findings and reassessing the diagnosis if clinical course is atypical or we are having some other differential diagnosis. So again, if you see the key electrodiagnostic findings in subtypes of GBS. So in AIDP, there is a prolonged distal latencies, slowed conduction velocity, so conduction block, F wave abnormality will be there. In MN, that is motor variant, so reduced compound muscle action potential amplitude with a preserved sensory response. But when it is a sensory variant, so reduced like compound motor action potential and sensory nerve action potential amplitude is going to be there. So this is the like take home on the electrodiagnostic findings in GBS subtypes. So again, this is the in-depth table. Okay, so in different variant including Miller Fisher, if you see often normal motor and sensory nerve conduction study, but sometimes may show reduced like sensory action potential also. Basically, like it had a triad like ophthalmoplegia, ataxia, areflexia, so anti-GQ1B antibody positive. So like that, you can just go through this. So electrodiagnostic findings in different subtypes of the GB syndrome. But at least, so the previous table you should remember. So this table you should remember, so in terms of differentiating the subtype. So move on to our case. What are the treatment options available for our GB syndrome patient? We have narrowed down our discussion and diagnosis towards GB syndrome. Okay, so now after you established the diagnosis, so what is your therapy in between IVIG and that of the plasmapheresis? Okay, so remember, so IVIG, if you are going to consider, so you need to exclude there is no like renal dysfunction or severe volume overload or IgA deficiency. Okay, so like IgA nephropathy and all. So dosage is so 400 milligram per kg per day for 5 days you need to give. So in terms of indication, it is non-inferior to plasmapheresis. So combination, there is no add-on advantage. There is IVIG with that of the plasmapheresis. So if you see the plasmapheresis, 4 to 6 exchange over 10 to 4 days. Every alternative day you can do 4 or 5 cycles of the plasmapheresis, which is preferred when there is a acute respiratory involvement, because so the effect of plasmapheresis is little early as compared to that of the IVIG. When there is a respiratory system involvement, you can go for the plasmapheresis. So if patient is unstable hemodynamically or ongoing sepsis is there, so then plasmapheresis we can avoid. So again, it should not be clubbed with that of the IVIG. Suppose you given an IVIG, so immediately if you done a plasmapheresis, so IVIG is going to have a half-life of around 21 days. So there is a possibility some amount of IVIG may be removed with the plasmapheresis. Very, very important. Okay. So in terms of summary, IVIG and plasmapheresis are equally effective in improving short-term and long-term outcome in GB syndrome. IVIG is generally preferred due to its ease of administration, fewer complication, and logistic advantage like giving the plasma, arranging the machine, and invasiveness and all those things. So combination therapy, that is IVIG with plasmapheresis, so does not offer additional benefit and it is not recommended. So timing of therapy, preferably within the first 2 weeks of onset, so is crucial for the optimal benefit. So delayed initiation of therapy, so outcome is questioned. So repeating IVIG, if you given one dose of the full course of the IVIG, so it is not routinely supported, so unless clear clinical deterioration occurs and should be evaluated case by case. So it is not recommended to give repeat IVIG after completing the full course. So again, this is the available evidence in terms of RCTs, meta-analysis. Okay, so lots of data including 2022 data from the Lancet. So lots of data is available comparing plasmapheresis for that of the IVIG. So IVIG is not equal, means equal to plasmapheresis in efficacy, no added benefit of combination. So plasmapheresis improved the outcome and shortened the disease course. No additional benefit of combination therapy. IVIG and plasma equally effective. So plasma exchange more invasive. Early IVIG is most effective. That is less than 2 weeks you need to give. Okay. Unclear benefit for repeated dosing. Second dose of IVIG is not a standard of practice. No significant difference in long-term recovery between IVIG and plasma exchange. Okay. So poor prognosis associated with delayed treatment. So this is the inference on the IVIG versus plasmapheresis according to currently available RCTs and that of the meta-analysis. Very, very important. So some examiner are interested in evidence. So on all this comparison and all. So should we give steroid to our patient? Is there any role of steroid in AIDP of our patient? That is one of the subtype of the GB syndrome. Definitely no. So no corticosteroids. So they are not beneficial and not recommended in GB syndrome. So there are lots of RCTs have been done already. So on corticosteroid in AIDP or any other GB syndrome. So steroids are not beneficial. Oral steroid may delay the recovery. So adding steroid to IVIG is not recommended. Say some practice. So giving pulse dose of methylprednisolone before IVIG, that is not recommended. Okay. So no improvement in outcome with a steroid. Oral steroids are contraindicated. Again, so strong recommendation against the usage of steroid. In some instances, it may deteriorate the patient's condition and all. No for steroid in AADP or other variants of the GB syndrome. If you come back to our patient, so on day 2 of admission, patient developed facial weakness. So dysphagia, its forced vital capacity is 14 ml per kg. So he started to showing the signs of labile blood pressure and is having a sinus tachycardia. So what complications are now emerging? Okay, so patient is having, if you see, so some sort of compromised blood pressure, tachycardia. So there is a like affecting is forced vital capacity. What's happening here? Okay. So basically, so this patient is having a bulbar involvement, so autonomic dysfunction and impending respiratory failure. So how are going to manage or like monitor this patient? So negative inspiratory force, forced vital capacity. So cough, peak flow velocity. So all these things you can monitor serially. So consider intubation if forced vital capacity is less than 15 ml per kg or if it is rapidly declining from that of the baseline. So that is how we are going to examine. So when will you consider intubating the patient with GB syndrome? Okay, what other things you need to answer in your exam. So is ABG is a reliable thing? So remember, so look for type 2 respiratory failure, that is increase in PCO2, like compromised oxygenation. You can get chest X-ray, lung ultrasound to assess is there any atelectasis or aspiration. So because of the bulbar involvement, so do ultrasound of the diaphragm. So is there any decreased excursion? So bedside spirometry. So with serial decline in forced vital capacity, you can observe as an indication for intubation. So if you see the limitations of ABG alone, so ABG changes are often late. So patients may have a significant diaphragmatic weakness before we are going to have the ABG deterioration. That's why don't rely or wait till the ABG values are going to get deteriorated for intubating a patient. So normal ABG does not rule out the need for intubation and mechanical ventilation. So again, this is the table which suggests the indication for intubation. So if patient is having a forced vital capacity of less than 15 to 20 ml per kg or less than overall 1 liter in adults, negative inspiratory force of less than minus 30 centimeter. So peak expiratory flow rate is less than 40% of the predicted. So PCO2 is raised more than 45. So PaO2 is less than 60 or SpO2 less than 90. Bulbar dysfunction like dysphagia, pooling of secretion, weak cough, so which increases the risk of aspiration. Autonomic dysfunction like suddenly bradycardia, arrhythmia or fluctuating blood pressure, so which may predispose or precedes the cardiopulmonary instability. So clinical signs like there is a worsening weakness, especially neck and diaphragm involvement. So head lift test is not able to lift the head. So inability to count 20 in one breath. So which is one of the bedside marker of the fatigue. So then you can consider these are the indication for endotracheal intubation and mechanical ventilation. Okay. So what are the limitation of respiratory mechanism? I told forced vital capacity, negative inspiratory force and all. So is there any clarity we can do in all the patients? It's having a limitation. If you see, so sometimes like vital capacity, it is effort dependent. So may appear normal in the early period. It is not specific. We need a full cooperation of the patient. Remember, around 30% of the patients are not able to cooperate for the like measuring the respiratory mechanics, including that of the vital capacity. So negative inspiratory force, so highly effort dependent, okay, less sensitive for early bulbar weakness. So maximum expiratory pressure, so which is often omitted, so which evaluate the cough strength, but underused in clinical practice. Okay. So single breath count, so it is very subjective, can vary due to anxiety or poor understanding. When patient is not able to understand what we are telling, so then it not going to yield anything. So trend based tools, okay, so we need to get the serial data. If there is a lack of serial data, it doesn't mean. So additional concern in GB syndrome, so bulbar dysfunction may not reflect like vital capacity or negative inspiratory force, but increases like aspiration. Then also we need to intubate the patient. So autonomic instability can lead to unpredictable deterioration, so not captured by respiratory mechanics. That is one of the drawback if they are already having autonomic instability. So rapid progression, some patient may rapidly go from mild symptoms to respiratory arrest, so despite preserved mechanics, okay, in the early hours. So you done within 1 week respiratory mechanism which looks normal, next week may patient get progress to the rapid worsening of the symptoms. Okay, that you need to remember. So this is one possible approach for ventilatory management so of a patient so with either myasthenia gravis or GB syndrome. So evaluate the patient's work of breathing, ability to protect the airway. So severe distress, other indication for intubation, go ahead and tube. So no respiratory distress, at rest, no tachypnea, so no ventilator support is needed. So mild to moderate distress and immediately no indication for intubation, so is a potential candidate for BiPAP or HFNC. So then if patient is contraindicated for BiPAP, for example, bulbar involvement is there, significant secretion pooling, nausea, vomiting. So if BiPAP is contraindicated, so then you can try with high flow nasal cannula. So if like clinical improvement, so decrease the respiratory rate, improve patient comfort. So if yes, you can continue the high flow nasal cannula. If there is no clinical improvement, discontinue. Okay. So may also titrate down decreasing the flow. So, but if it is not helping, so then you need to consider for the endotracheal intubation. Suppose if no contraindication for BiPAP, okay, so then like trial of BiPAP we can give. So if there is a clinical improvement, so decreased respiratory rate, improved patient comfort. If the answer is, we can continue the BiPAP. If there is no clinical improvement, so high flow nasal cannula, if that is not serving the purpose, so then you can take a call on intubating the patient. So this is one of the possible approach for ventilator support in so GB syndrome. So we got some more data. Okay, on day 3 in our patient, so his respiratory rate is 34, is saturating 89% on room air. BP is 134 by 76. So his GCS is E4, M5, means V5, E4, V5 and that of the M6. So his use of auxiliary muscles of respiration is there. Unable to complete full sentence. We got a ABG. pH is 7.28, PCO2 is 55, PaO2 61, bicarb is 24, lactate 1.8, saturating 88%. Okay. So again, if you see his parameters, so there is a compromised vital capacity, which is 10 ml per kg. Negative inspiratory pressure is -18. So maximum expiratory pressure, which is 30 centimeter of water. Single breath count hardly is able to count 8. So this patient is having a hypoxemia, hypercapnia, so critically low value of vital capacity and negative inspiratory force. So is having a fatigue, bulbar symptoms are there. Okay, so unable to complete a full sentence and all. So these are the clear indication. So definitely require so elective intubation. Okay, so this is the data from our patient, so who is at the verge of requiring the intubation and mechanical ventilation. So this patient is intubated because of his respiratory failure issues and all. So what are the supportive care once you intubated the patient? So once you done a definitive therapy, what general supportive care you consider in critically ill GB syndrome? So remember, most of the points are common for many of the patients who are in ICU. So basically, like general and systemic management, so airway and respiratory, okay, monitor all the respiratory mechanic. So like consider for intubation, chest physio. So nutrition, very very important. So calorie target 25 to 30 kilocalories per kg per day. Protein at least around 1.2 to 2 gram per kg per day. Monitor for refeeding syndrome if patient was kept NPO for prolonged time because of the worry about the airway and all. So remember, your viva may stuck at the level of nutrition itself. Very very important. So fluid electrolyte management, avoid overhydration, watch for SIADH, that is hyponatremia. So daily fluid balance electrolyte you need to monitor. So DVT prophylaxis, low molecular weight heparin or unfractionated heparin. If there is any contraindication, then we can go for mechanical prophylaxis like intermittent cough compression devices. So stockings nowadays nobody will consider, even a TED stockings also, which helps in only in some sort of the peripheral neuropathy, but definitely not serve as a purpose of like DVT prophylaxis. Bladder bowel care, so monitor for urinary retention, intermittent catheterization might be required. So maintain the regular bowel regimen. So monitor other labs like serial ABG, electrolyte, RFT, LFT. Monitor for rhabdomyolysis like creatine kinase level. Regular neurological examination is very very important. So this is one sort of so general and systemic management. So next comes complication prevention and rehabilitation. These are other supportive measures. Okay, so back care, skin care, positioning. So turn patient every second hourly. Use pressure relieving mattresses, that is alpha airbed. So daily skin inspection. So passive physio, passive range of motion to prevent contractures. Physio, initiate passive physio early. So gradual active physiotherapy as tolerated, prevent muscle wasting and joint stiffness. So proper infection control policies, strict hand hygiene. So all bundle care, okay, sterile suctioning with a suction catheter you need to practice. So pain management, so they can have a neuropathic pain. So you can give gabapentin, pregabalin, carbamazepine. So but avoid excessive usage of the opioids, which may compromise the respiratory system. Autonomic dysfunction, you need to keep a watch continuously, ECG, BP monitoring. So sometimes you might require to give like alpha agonists like midodrine, vasopressor for hypotension. So monitor for bradycardia or tachyarrhythmia. Psychological support is very essential. So family and patient reassurance. address the ICU delirium early, consider for psychiatric support. So these are some of the supportive care you need to consider in GB syndrome. So next, move on to our patient. So there is a progression, difficulty in weaning. Okay. So despite of IVIG therapy, the patient shows minimal improvement after 10 days. So he is on mechanical ventilation for more than 10 days with a poor spontaneous effort and poor forced vital capacity. No, like very good expected recovery is happening. So then what we done? We done a tracheostomy on day 11. So what are the indications for early tracheostomy in GB syndrome? Okay, so remember, like anticipated prolonged ventilation. If you think, okay, it's going to take more than 2 weeks, bulbar dysfunction is persisting, repeated failed spontaneous breathing trial. So to prevent laryngeal trauma from prolonged intubation, so better to go for the tracheostomy in GB syndrome. So these are some of the indications for early tracheostomy in GB syndrome. So next, on day 14, our patient, what he had, like the patient started developing fever. So his temperature is 39.2 degrees Celsius, increased secretion, FiO2 requirement. So from 30% it becomes 60%. What is your approach at this level? So remember, these kind of questions are very, very common. So you started with the GB syndrome. After your many discussion in and around GB syndrome, your viva may go into other complication in ICU. So this is what happening in our patient. So he started having a fever, increased secretion, increase in FiO2 requirement on ventilator. Approach. So what we done? So we sent like ET tube secretion, that is endotracheal tube secretion for culture sensitivity. So we done an X-ray. This is the X-ray here. So we got culture sensitivity report. If you see, organism is Pseudomonas. So large, flat, okay, greenish pigment producing colony Pseudomonas, which is a GNB. So heavy growth more than 10 to the power of 5. So colony forming unit per ml. So if you see, this is the sensitivity report. So it is resistant to many antibiotics, sensitive to carbapenems and intermediate to colistin. So remember, CLSI not recommend doing sensitivity test reporting for polymyxin B, but like if you follow UCAST European guidelines, which also suggest for doing the sensitivity including polymyxin B. So colistin and polymyxin B both are showing intermediate and carbapenem showing the sensitive. Okay, so how you are going to interpret this X-ray and culture sensitivity report? So in between they will show you some reports of the culture sensitivity and the X-ray. Very, very important. So this is how your viva in a real way is going to happen at the bedside, or so case based approach for your EDIC part 2. So here if you see X-ray showing some sort of the right sided, so infiltrates in the lower zone. So like chest X-ray shows right lower zone infiltrates with patchy consolidation. So like our culture grows ESBL Pseudomonas aeruginosa, which is sensitive to meropenem. Because if you see, so the Pseudomonas is resistant to most of the beta-lactam and beta-lactam combination. Okay, so then it is a ESBL organism. Remember, when we get a ESBL organism, okay, so approach is going to be different as compared to giving antibiotics with a BL-BLI combination. So what is your approach to diagnose ventilator associated pneumonia in this context? So definitely there is an increase in oxygen requirement, increase in secretion, X-ray showing infiltrate, fever is there, and organism isolation, which is a ESBL organism. Okay, so basically clinical signs of fever, purulent secretion, hypoxia. So radiologically new or persistent infiltrates. We done a either quantitatively ball we can do, or endotracheal aspirate culture we have done, or you can use clinical pulmonary infection score if the diagnosis is uncertain. But most of the time we are going to have a clinical and X-ray ventilator requirement. Okay, so secretion, culture, all these things we are going to use for the diagnosis of ventilator associated pneumonia. Here your viva may move towards possible, probable VAP, possible VAP, definitive VAP and all. so that you should be aware. Okay, so basically our gentleman with a GB syndrome is having a ventilator associated pneumonia which looks like an ESBL organism. So what is your antibiotic strategy for this patient? So this is your next OIVA question. Okay, so ESBL, remember, option is going to be carbapenem. So that too, when you have the BL-BLI combination, like your MIC is going to be less than 2, then only you can use the BL-BLI combination for ESBL organism. Otherwise, the drug of choice is going to be carbapenem. So this is what we started, meropenem. So 2 gram stat followed by 1 gram IV 8 hourly. So as a 3-hour infusion, because meropenem work by time dependent killing. So duration around 7 days. So again, it depends upon the response to therapy. If WBC is normalized, okay, if no fever, infiltrates are disappearing, oxygenation improved, no increase in the PEEP requirement, so then somewhere around 7 to 10 days you can stop the antibiotic which we given for ESBL Pseudomonas. So move on to our patient. So on day 20, so nursing staff was turning the patient for chest physio. Okay, so he developed sudden bradycardia. So his heart rate went down to 30, had a asystole. So immediately CPR started. So ROSC achieved within 1 minute. Okay, so this is what happened almost near into 3 weeks. He had one episode of bradycardia and cardiac arrest. So and required the CPR with ROC of 1 minute. So what's happening here? So what are the possible causes of cardiac arrest in GB syndrome? So remember, so autonomic dysfunction is one of the commonest cause of cardiac arrest in GB syndrome that can cause bradycardia, hypotension and arrhythmia. So others like vagal stimulation during suctioning and repositioning. That's why don't vigorously do suctioning in a GB syndrome. There is a tracheal suctioning and all. You might have a vagal nerve stimulation with a bradycardia, or it may be because of electrolyte imbalance, because if patient received IVIG, our gentleman received the IVIG therapy, it is known to cause hypokalemia. Sometimes, rarely, patient is having a VAP. So sepsis related myocardial depression, so sepsis cardiomyopathy can also at the extreme can cause some sort of the cardiac dysfunction, cardiac arrest and all, which is a rare instance. Okay, so how would you monitor and manage autonomic dysfunction in a patient with a GB syndrome? So how you are going to monitor? Okay, so basically you need to monitor ECG with heart rate with a continuous ECG, look for brady and tachycardia. So BP, particularly use arterial line. The patient is unstable hemodynamically. Temperature monitoring for both hypo and hyperthermia. So respiratory mechanics, which we already discussed, including ABG. Urine output, better monitor hourly output with a Foley catheter. So GI motility, they can have both ileus, gastric residual is going to be increased, or they can have a diarrhea also because of the autonomic dysfunction. So that those are the parameters you need to monitor. So in terms of therapy for autonomic dysfunction, remember if they have a bradycardia asystole, always keep ready atropine filled like syringe. This is the examiner is going to ask. Sometime a patient is having a too many episodes, so better to like keep the temporary pacemaker inserted. So that is very important. So tachyarrhythmia, we can use beta blocker with very caution. Avoid hypotension. Okay, we can use ivabradine if there is only pure problem with that of the heart rate. So if patient is having hypertension as a part of autonomic instability, so short acting agents like labetalol, esmolol, nicodipine we can give, which we can titrate. If patient is having hypotension, volume resuscitation, vasopressor, preferably NORAD, phenylephrine, for pure alpha action we can use. If they have a orthostatic hypotension, compression stocking, gradual mobilization, fludrocortisone or midodrine we can use. So sweating abnormalities, so we can control the regulate the temperature with active warming or cooling devices. Urinary retention, so like do the bladder scan for any residual urine, put the Foley's catheter for hourly monitoring. So GI dysmotility, so nasogastric decompression, prokinetic agents, so monitor for both constipation and that of the ileus. That is how we are going to manage the autonomic dysfunction in GB syndrome. So what are the predictors of poor outcome in GB syndrome? Okay, so our patient received the IVIG, but still there is no total response. But in general, what are the poor outcome predictors in GB syndrome? So remember, so rapid progression to quadriplegia within 7 days, and requirement of mechanical ventilation. So neurologically, severe muscle weakness at presentation, like if the MRC sum score is less than 40 or bulbar involvement. So autonomic instability like labile blood pressure, cardiac arrhythmia, urinary retention. Okay, so electrodiagnostic test, like if they are having an axonal subtype, so if it is AMN or AMSON, both motor or sensory, absent motor response, severe conduction block, that also suggests the poor prognosis. So CSF, early normal CSF protein within first week may indicate axonal type. So then it is like poor prognosis. Age and comorbidities, age more than 60 year, presence of other comorbidities like diabetes, cardiac disease, poor prognosis. Other indicators like delay in initiation of IVIG, means if you initiate the therapy very delayed, like both IVIG or plasmapheresis, or if they have the precipitating factor as a Campylobacter jejuni. So all these things are the poor prognostic indicators in GB syndrome. Very, very important. At least remember 2 or 3 poor prognostic indicators. Then we can use something called so Erasmus GBS outcome score. So it include age less than 40, 0, 41 to 60, 1 point, more than 60 is 2 point. So presence of preceding diarrhea, like so no diarrhea 0 point. So diarrhea is there 1 point. MRC sum score at hospital more than or equal to 51, 0 0.41 to 51 point, less than 42 point. Okay, so you club all the score. So the score is somewhere between 0 to 5. If the Erasmus GBS outcome score that is 0 to 1, they are low risk. Okay, so predicting risk of inability to walk at 6 months, so they are low risk at walking at the 6 months. Okay, 2 to 3 score, they are moderate risk. So 4 to 5 high risk. Note that MRC sum score ranges from 0 to 60. It assesses the strength in 6 muscle group bilaterally with a score of 0 to 5 in each muscle group. So Erasmus GBS outcome score typically assessed within the first week of hospital admission. A higher EGOS, that is Erasmus GBS outcome score, predict worse outcome in terms of independent ambulation. So that is a 6 months walking ability. It's going to assess by using so Erasmus GBS outcome score. Very, very important. Okay. So what long-term care aspects are important in GB syndrome? So definitely physiotherapy, occupation therapy, rehabilitation, pain control, psychological support, and monitor and manage the autonomic symptoms. So that is a long-term need in any of the patient with the GB syndrome. Okay. So can you comment on some numbers on morbidity and mortality in GB syndrome? Means what percentage of the mortality and other morbidity in a GB syndrome patient? At least you should know the mortality incidence in GB syndrome. So overall mortality is around 3 to 7%. So death usually due to autonomic dysfunction or respiratory failure or sepsis. So ventilator requirement in around 20 to 30% usually within the first week of symptom onset. So residual motor deficit at 1 year can happen in 15 to 20%. So severe disability, that is unable to walk without any support. Full recovery within 6 to 12 months in about 60 to 80%. Many regain ambulation at 6 months. So relapse, so treatment related fluctuation can happen, relapse can happen in 5 to 10%. So may occur even after IVIG or plasmapheresis. So chronic GBS or AIDP to CIDP conversion in less than 5%. So that is chronic inflammatory demyelinating polyneuropathy. Okay. So mortality is around 3 to 7% with the GB syndrome. So our patient ICU course, if you see, after doing the tracheostomy, we attempted multiple weaning attempts which were unsuccessful due to neuromuscular weakness. So managed thoroughly with a lung protective ventilation, treated the concurrent pneumonia. So he's having a recurrent failed weaning. Okay. So what are the different causes of weaning failure in our patient? So how you are going to evaluate? So you can remember this mnemonic. So A, B, C, D, E, F of the weaning failure. So airway issues, like is there any excessive secretion, so airway edema, airway obstruction, tracheomalacia, so brain dysfunction, whether he's having delirium, altered sensorium, so inadequate drive to sedation, drive due to over sedation or encephalopathy, cardiac dysfunction, weaning failure because of the cardiac origin. Okay, they might be having diastolic dysfunction, arrhythmia, so ischemia when you put a patient on spontaneous breathing because of the supply demand mismatch. So diaphragmatic dysfunction, so may manifest as muscle fatigue ICU acquired weakness, that is critical illness, polyneuropathy, myopathy, can have an involvement of diaphragm, okay, or rarely it may be because of phrenic nerve involvement also. So electrolyte endocrine disturbances, hypophosphatemia will lead to respiratory muscle weakness, hypokalemia, adrenal insufficiency, thyroid dysfunction. So you need to evaluate when patient is failing repeated attempts of weaning. So fever, fatigue, okay, so it increases the oxygen demand, metabolic rate. So fatigue may impair the muscle function. So this is just at least for your completion sake, you can remember. So A, B, C, D, E, F of the weaning failure like reasons. Okay. So what we done? So treated his underlying dyselectrolemia. He was having hypophosphatemia, hypokalemia that is being treated. So as a cause for his weaning failure. So he successfully transitioned from invasive ventilator to portable BiPAP. Through the tracheostomy, we connected the portable BiPAP with like unidirectional valve, leak valve we call it as. So then we give an intermittent TP trial and aggressive chest physiotherapy has been continued. So rehabilitation and recovery, if you see, he's been mobilized out of the bed to chair with assistance. So minimal oxygen support, no inotrope or vasopressor. So pneumonia is totally resolved. So chest X-ray improved down the means like resolved down the line. So discharged from ICU, patient shifted to ward in stable condition with the ongoing further physiotherapy and rehabilitation. Okay. So this is about the GB syndrome discussion. Some are specific question, some are general questions. Okay, this is the way how an examiner expect the answer and the questions you can expect from an examiner. So we'll come back with one more live case-based discussion. Till that time, revise, watch this video, recall. Okay. So we'll no questions. So if any questions, you can directly post to me. Okay. So we'll come back again as I told with the one more case discussion.